All right. So we have a 70-year-old female patient who was diagnosed with fracture of the left femoral neck. The femoral neck accompanied by a disruption of a ligament of the head of the femur. The branch of the following artery is damaged. So look at it. We are talking about what? A fracture of the neck, a structure of the neck. And we said this is only common in old age. When they fall down, they usually have a fracture of the neck, of the femur or the thigh bone. Now, they say it's accompanied by a disruption of a ligament of the head of the femur. So what branch of artery is being damaged? So in anatomy, or in the human anatomy, the ligament of the head of the femur, is called the round ligament of the femur, or another name is called the round ligament of the femur. The round ligament of the femur. We can also have the ligamentum teres, or the foveal ligament, Foveal, the foveal ligament. They all referring to the ligament of the head of the femur. Okay. Now, this ligament is located in the hip. It is located in the hip, and it contains within it the acetabular branch of the obturator artery. But the thing is, there's a disruption of the ligament of the head of the femur. So you have to now find out what is found in the head of the femur, or what artery passes through that place. What artery passes through that place, for which, when there's a damage to the ligament of the head of the femur, that artery can also be damaged. And over here, we are looking at what? The obturator artery. The obturator artery, because within this ligament, which connects it into the acetabulum, within it, we have the obturator artery. We have the obturator artery. So that is what we are looking for over here. So here, we are looking at what? Obturator artery. Obturator artery. So your answer is C. Your answer is C. Your answer is C. All right. Dr. Faustina, if you send it, I might not know. So just let me know when you send it.
Okay.
Yes. Okay. All right. So we have a woman who underwent an operation on account of extrauterine. When we talk about extrauterine, we're talking about what? Ectopic pregnancy, or something that is out of norm, or something that is not at the right place. So we are having an extrauterine pregnancy, that is ectopic pregnancy or tubal pregnancy. Now, in course of the operation, the surgeon should ligate which artery? That's what they're asking us.
Dr. Baha, please have sent it.
Okay. The surgeon should ligate which artery? So ligate which artery? So over here, you are looking at an artery that perhaps is connecting the uterus and then the ovary, isn't it? Those are the kind of arteries you are going to be looking at for. So over here, simply, we are going to look at what? The uterine and then the ovarian arteries. The uterine and then the ovarian artery, because all of these things, of course, are connected to the ovary and then the womb as well. So we're looking at the uterine and then the ovarian artery. The uterine and then the ovarian artery. So these are what we are going to be looking at for. So when you cut them, of course, blood will not flow to these areas, or the body and the fundus of the uterus. There will be no blood supply to those areas. There will be no blood supply to those areas. So over here, we're looking at the ovarian artery. The ovarian artery. So your answer should be A, uterine and then the ovarian artery. Uterine and then the ovarian artery. All right. Good. Now we have a 6-month-old baby, a 6-month-old baby who is ill. 6-month-old baby who is ill with bronchitis, was taken for an X-ray of the chest. An X-ray of the chest. apart from changes associated with the bronchi, the X-ray film showed a shadow of the thymus gland. What might have caused such changes? Again, we are having a child suffering from what? Bronchitis, which actually is not very, very common in children, because children normally develop what we call bronchiolitis. So for a child to suffer from bronchitis, that's to tell you that this could be a very serious thing. So this child is what? Suffering from what? Bronchitis. Is suffering from what? Bronchitis. Was taken for an X-ray of the chest. Apart from the changes associated with the bronchi, the X-ray film showed a shadow of the thymus gland. So over here, the problem is not about the bronchitis, but the problem is the fact that there is a shadow on the thymus what? There's a shadow on the X-ray because of the thymus what? Gland. So what might have caused such changes? Now, this person is 6 months. And in 6 months, you know where your thymus is, right? Yes. You should know where your thymus is. Anatomically, you should know where your thymus is. So you ask yourself, what is the relationship between the age and thymus activity? That's what we need to know. The relationship between the thymus activity and age. Now, in neonate or in children who are just born, neonate, the thymus appears to have a considerable mass of 13.3 grams on the average. That is the mass of the the thymus. And you know, as you grow, I think I said it over here, as you grow, the thymus decreases or it shrinks in size. And those shrinkage are now replaced with fat tissues. So as you begin to grow like 50 years and above, your thymus actually what? Shrink. About 90% will turn into what? Into fat. About 90% of the thymus will turn into fat. It will turn into what? Into fat. So you must know that it will turn into fat. That's why naturally your immune system, when you begin to grow, always go down. Naturally, when you grow, your immune system will be underperforming. And that is normal. So again, for a child of a unit of 6 months old, that should tell you that whatever that you are seeing, it could be normal. This could be what? Normal. Why am I saying it's normal? Because the mass of the thymus is about 13.3 grams, which is actually what? Quite big. So you definitely, when you use an X-ray, you definitely see a shadow of the thymus gland, and that is normal. That is normal. That is normal. So this is not the effect of the bronchitis or there is thymus inflammation, or no, it is a normal variant. This is what? A normal variant. Like I said, as you grow, they begin to what? To shrink. They begin to shrink. So here we're talking about what? About B. 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 The condition is normal. Condition is normal. A 7-year-old child cannot abduct the shoulder. When we say abduct, cannot move the shoulders or the upper arm laterally from the body or away from the body. Away from the body. That's what abduction. Now, if you bring it towards your body, it is called what? Adduction. That is ADD, adduction. But this is what? Abduction, taking it away from the shoulder. The person cannot do that. So you start thinking about it. What could be? What could it be? What could it be? What could it be? Isn't it? Now, this led to what? Okay, cannot abduct, raise to the horizontal level. That means you cannot even raise the arm to the horizontal level. You can't make it straight. He can raise the hand to the face, okay? Only with the dorsal side, with abduction of the shoulder. That's with the help of the supraspinous muscle, buccal arm. Active function of what muscle is absent. So what muscle is absent in this case? What muscle is absent in this case? Don't forget, we are talking about the shoulder joint. We are talking about the shoulder joint, the shoulder joint, the shoulder joint, the shoulder joint. So don't confuse this one, the teres major, the teres minor with deltoid, because over here, the majority of the muscles around the shoulder is made up of what we call the deltoid muscles, or the deltoid muscle, the deltoid muscle, the deltoid muscle. So that is what we are looking at for, the deltoid, the deltoid. And that is involved in abduction. It is involved in abduction. Please take note. It is involved in abduction. That is taking the arm away from the body. That muscle is involved in that. So your answer should be E. Your answer should be E. All right. A 7-year-old girl has signs of anemia. Okay. Lab examination revealed pyruvate kinase deficiency. Guys, we've talked about pyruvate kinase in pharmacology, in physiology, and so we've talked about like 10,000 times about this, this enzyme. Now, what process disturbance plays the main role in anemia development? What plays a role in anemia development? So anytime there is a pyruvate kinase deficiency, that's in erythrocyte. And don't forget, erythrocyte, that's what? Red blood cells. And there is pyruvate deficiency. What it means is that during glycolysis, these cannot enter into what? The Krebs cycle. They cannot enter into what? The Krebs cycle. And the Krebs cycle is what eventually will lead to the production of what? The energies that we need, or it will later enter into the electron transport chain to produce the energy that we need when we do exercises and when we do other stuff. So when there is no pyruvate kinase, when there is pyruvate kinase deficiency, again, it tells us that we are having an anaerobic glycolysis. That means in the absence of what? Oxygen. In the absence of oxygen, we are having anaerobic. Because in aerobic glycolysis, it is done in the presence of what? Of oxygen. And that occurs in the mitochondria. But when there's a deficiency, it means we are having what? An anaerobic what? Glycolysis. Anaerobic. And that's why if people like this are doing exercise, they can have muscle pains because lactic acid always results from anaerobic glycolysis. Lactic acid or lactate result from anaerobic glycolysis. So here we are looking at what? At E. Anaerobic glycolysis. A patient complained about being unable to adduct. Guy, look, adduct. That is bringing the arm towards itself, and look, abduct, moving the fingers away. You see, they say towards and away from the third finger. What muscle function is impaired? Guys, just look at your fingers, for instance. Try to open it. Now, if you try to open it, you will see something like a web, isn't it? Like a web, isn't it? Yes, those muscles are what is causing what we are having over here. And those muscles are called interosseous muscles. They are called interosseous muscles. It's just like checking your tibia and then the fibula. Between the tibia and the fibula, we have what's called the interosseous muscle or the interosseous membrane. Interosseous membrane. So over here, we're looking at what? The interosseous muscles. So your answer should be A. Interosseous muscles. Interosseous muscles. All right. A 45-year-old patient was admitted to the surgical department with a complaint of abrupt pain in the epigastric area. After examination, he was diagnosed with a perforated ulcer posterior of the posterior wall of the stomach. Guys, we have done this before. So where did the content of the stomach flow out while perforation? Guys, we've done this one when we spoke about the basals, isn't it? When we spoke about the basals, we talked about this. We have the lesser sac, also known as the omental basa, and of course, and this is a cavity inside the abdomen that is formed by the lesser and the greater omentum, and it is lying posteriorly to the stomach. It is lying posteriorly to the stomach. So over here, our clue here is what? Posteriorly. Posteriorly, there's a perforation of the posterior wall of the stomach, and that's over here. Easily, we can go in for what? From the lesser basa, which is also known as what? The omental basa. The omental basa. We've done this before. So this one here is what? Omental buzzer. Omental buzzer. All right. A 25-year-old patient complained of decreased vision, that is inability to see very well. Accommodation disorders. When we talk about accommodation, the ability of the eye to constrict and to relax when viewing far and near objects. That is what accommodation of the eye. That is why anytime I'm bringing someone is bringing an object closer to your eyes, immediately your people will begin to constrict because the object is coming too close. But when it's far, it dilates to be able to see very well. The same phenomenon is happening here. But this person is having a disorder of that functionality. A disorder of that functionality. A disorder of that functionality. So that means that the muscles could be impaired, isn't it? The muscles that help us to do that could be impaired. And those are called the ciliary muscles. The ciliary muscles. Those are the muscles that are found inside the eye. Now look at it. We are having a dilated people. Dilated, not reacting to light where revealed. It was not reacting to light. Now, what function of the muscles is disturbed? Definitely, you have to know that if the pupil has been dilated and it cannot narrow, that means a narrowing of the pupil has been impaired. And again, the muscles that are involved have also be impaired. So over here, you are looking at at the how do you call it? Pupil narrow muscles and the ciliary muscles and the pupil narrowing muscles. These are the muscles that are affected. These muscles are affected. So your answer is A. Don't confuse it with dilating muscles. It's different thing. Already there's dilation, but it cannot, constrict or it cannot undergo narrowing. And that's why the narrowing part of the pupil has been affected. And again, the ciliary muscle, which is involved in all the muscles control, has also been be affected. So over here, we're looking at at A as our likely muscles that have been disturbed. So the answer is A. Microspecimen of the spinal cord. Microspecimen of the spinal cord contains a nucleus that should be analyzed, okay? The neurons form motor endings in the skeletal muscles. So over here, we are looking at anterior horn. Because when they say it's a motor ending, that means that this place is going to lead to motor function. When we say motor function, we are talking about Activities. So just like when muscle fibers passes through your muscles, you begin to contract, isn't it? That is what is happening over here. So we're going to study this nucleus that is having its ending inside the skeletal muscle. That means when those nucleus are activated, the skeletal muscles will start operating. So those are called the motor functions. So and usually the motor functions are found on the anterior horn. The anterior horn always produces motor function, whilst the posterior horn produces a sensory functions. The ability to sense. Okay, but to take action, you need the motor horn or the motor neurons. So what nucleus of the spinal cord was this meant for? Of course, we are looking at the anterior horn. So it's right for us to say we are having the proper nucleus of the anterior horn. The proper nucleus of the anterior horn. And this, the same as saying that the gray matter, that is the gray matter of the spinal cord. So over here, we're looking at D, anterior horn, proper nucleus of the anterior horn. They have what we call the alpha motor neurons. And these alpha motor neurons help the muscles to contract or help the muscles to move, help the muscles to do so many things. Okay, so your ability to run is because of this proper nucleus of the anterior horn that is helping you to run. So it is stimulating the muscles for you to run. That's the motor function. So over here, we are looking at D. All right. Good. A man with a cut wound of his right foot sole was admitted to the hospital. The patient has a limited elevation of the lateral foot edge, the lateral. Now, when we talk about lateral, talk about the outside of your leg, the outside, not the inside, the outside. So you can just look down on your leg and look at it. Not the one inside, but the one outside. There's a problem on the outside. Now, in the course of wound management, the injury of a muscle tendon was revealed. The injury of a muscle tendon was revealed. What muscle is it? So again, we are talking about the lateral side. So anatomically, you need to look at the muscles that are found inside the leg. The muscles that are found inside the leg. That's where we can begin from. Muscles that are found inside the leg. So first of all, write this. You can write this down. The muscles inside the how do you call it? The leg area. Together we call them the peroneus muscles. The peroneus muscles. The peroneus muscles. And we have three muscles. Talking about the peroneus muscles, we have three of them. These are found in the leg. They are found in the lower part, or not the. I'm not talking about the thigh or the lower part of your leg. We're having three major muscles, but together we call them what? The peroneus muscles, or the perineal muscles. I don't know how you pronounce it. It's fine. Perineal muscles. So these are three in number. We have the longus, we have the brevis, and we have the tertius. Again, longus, brevis, tertius. Longus, brevis, tertius. Now, the longus and the brevis are both located in the lateral compartment of the leg. Now, when I say longus, it means long. When I say brevis, it means what? Short. So please don't get confused. It means short. So we have the long and then the short peroneal muscles. These are found on the lateral compartment of the leg. They are found on the lateral compartment of the leg, whilst the tertius is located in the anterior compartment. In the anterior compartment. Then again, the peroneal longus do what we call pronation. That means it helps in pronation of the leg, in abduction of the leg, and the flexion of the foot. That is the main function of the longus. Again, the longus helps in what? Pronation, helps in what? Abduction, and then helps in what? Inflection. The opposite will be true for the short peroneal muscle. The opposite will be true for it. And over here, they are telling us that the person is having a problem on the lateral foot. So it's either we are doing at the long peritoneal muscle or the short peritoneal muscle. Now, they say in the course of the wound management, the injury of a muscle tendon was revealed. And so what muscle was injured? So like I was saying, so over here, we're looking at two things. Either the long peroneal muscles or the short peroneal muscles. But then again, like I said, the longus helps in pronation, in abduction, and in inflection of the foot. And that's why there was a pain, or there was a limited elevation of the lateral side of the foot. There's limited elevation. That means you cannot do any pronation, any abduction, limited elevation. So over here, we're looking at the longus rather than the short peroneal muscle. So here we are looking at the longus or the long peroneal, muscle. So your answer is D. Don't confuse them. The answer is D. If I were you, whilst I'm talking about these things, find time to look at the anatomy of these muscles I'm talking about. Look at where they are. If you have a graphical presentation, it sticks better. Now, because of my time with a whole lot of stuff, I've not been able to bring some of these pictures, okay? Because it involves a whole lot of things. I have to go to the Google and go and download some pictures to help you. But then, Try and look at it. And I love it when the last time we finished and someone brought a question that I want to check it, and this is how the vesiculouterine, rectouterine, blah, 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 pouch is good. So try and get a picture. Then you understand this thing better. This is anatomy. Don't forget that. All right. So this is D. This is D. All right. A 35-year-old man with a trauma of his left hand was admitted to the trauma department. The cut wound of the palmar surface of the left hand. That's objectively. There's a cut wound of the palmar. When we say palmar, inside your palm, there is what? A wound, a cut wound of the left hand, the palm of the left hand. Now, the middle phalanges of the second to fifth fingers cannot bend. They cannot what? Bend. What muscles are damaged? What muscles are damaged? They cannot bend. That means flexing is difficult, isn't it? So that means you cannot close your hand. That's what it means. You can't close it because you can't bend. You can't close it. You can't close your hand. Okay? You can't close your hand. That's like being, they say a stingy boys association. So close your hand. That is called what? That means I cannot bend. So what muscle controls that? Or what muscle is responsible for that? What muscle is responsible for that? That is what the question is. And over here, the muscle is responsible for that. We call it the flexor digitorum superficialis. The flexor digitorum superficialis. That means superficial finger flexor. Again, the word flexing, so even tell you that it's talking about what? Flexing the arm. Flexing the arm. But we have the deep and then we have the superficial. By the superficial one that controls, how do you call it? These particular ones is the superficial ones that control it. The superficial ones that control these things. So over here, we're looking at what? At D. 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 So your answer here is what? Is D. Is D. Is D. So please do well to, check all these things out. That's how we learn. Do what you check all these things out. All right. A 38-year-old patient came to the traumatology center and complained about injury in his right hand. Again, there's a question on the right hand. The patient has a cut wound in the region, but this is a tender eminence on the right hand. Distal phalanges of the right finger of the first finger cannot be flexed. Again, you can't flex it. What muscle was injured? What muscle was injured? What muscle was injured? So again, we are looking at a flexor muscle. Flexor muscle. Now we'll talk about the tender eminence. This refers to a group of muscles on the palm of the human hand at the base of your thumb. So look at the base of your thumb. The muscles that are located there, these are called the tender group of muscles, or these are called the tender eminence. So look at it. Take a glance at it. Now we have the flexor pollicis. We have the flexor pollicis of the thumb. Flexor pollicis longus of the thumb. Flexor pollicis longus of the thumb. And this is a muscle inside the forearm and in the hand that flexes the thumb. So if your thumb, which happens to be your first finger, cannot be flexed, we are referring to what? The longus. The longus. Longus. So longus flexor muscle of the thumb. That is what we are looking for. And then the flexor, how do you call it? The flexor pollicis brevis, or the short one, that one deals with the proximal phalanges. The proximal phalanges. The proximal phalanges. It does not deal with the thumb directly, but the proximal. Don't forget, if you take your hand, for instance, we have the metacarpals, the carpals, we have the carpals, the metacarpals, before you have all those things coming up. So take note of these things. Some of these things is better explained with diagrams. is better explained with diagram. So when you look at the longus flexor, you see why we are saying that it is responsible for the flexing of your thumb. So if your thumb cannot be flexed, we are looking at what? The flexor longus. The flexor longus. All right. So the answer is C. All right. A patient with neuritis of the femoral nerve, that means inflammation of the femoral nerve, has a disturbed flexion of the thigh as well as a disturbed cruise extension in the knee joint. What muscle function is being disturbed? So over here we're having what? The thigh, and also what? We're having what? The knee joint. So what group of muscles are responsible for these things? So literally what it means is that you cannot squat. Try squatting. You will see that your thigh and then of course your knee will be involved. Your thigh and your knee will be involved. Your thigh and your knee. So this is called what? Squatting. Squat. So you can't do squatting. You can't do what? Squatting. And from the name, the squat or the squatting, there comes what we call the quadriceps muscles, or the quadriceps, how do you call it? Yeah, the quadriceps muscles of the thigh. The quadriceps muscles of the thigh. It's just like when you position yourself on the wall, position yourself on the wall, then you try to kneel down, not kneel down, but lower yourself a little bit. Those your thigh muscles and your knee will be paining you. These muscles that are involved are called the quadriceps muscles. The quadriceps muscles. And we are having a problem with flexing and then what? Extension of the knee joint. And that is the problem. So over here, we're looking at what? We're looking at what? The quadriceps. The quadriceps. The quadriceps. The quadriceps. The quadriceps. All right, the quadriceps. Now, the bicep and the triceps. Bicep is just the front part, the front part, while the triceps is the back part of the thigh. And that is just specific for the thigh. And then but over here is not only about the thigh, but we also want to look at what? The knee joint as well, or the knee as well. So you look, or you take all of them into perspective, and then there you are. So here we're looking at what? At A. In the specimen of one of the parts of the respiratory system, a tubular organ was found. A tubular organ was found. A tubular organ was found. It has a low epithelium, well-developed muscle tunic. There are glands and cartilages are absent. Name this organ. So even the option here to tell you that we're talking about the respiratory system. So which part of the respiratory system are not having cartilages? That's your question. Now you and I know that the trachea has cartilages, the larynx has cartilages, the main bronchus, they have cartilages. But the minor bronchus or the minor bronchi, they do not have, cartilages. They don't have cartilages. Although they're made up of a lot of what? Muscles. But they lack cartilages. The rest have cartilages. So here we are looking at what? At A. Again, try and get a diagram and see how. So these are more or less like the bronchioles. So the bronchioles do not have what? Cartilage. The bronchioles, they do not have what? Cartilages. All right. Where should the catheter for evacuation of a lymph from the thoracic lymph duct be inserted? Catheter for evacuation of the lymph from the thoracic lymph duct be inserted. Usually we insert it at the left venous corner. The left venous corner. This is like an anatomical position that you need to know. Sorry. The left venous corner. The left venous corner. This is the place that we put in the catheter to be able to drain anything from the thoracic lymphatic duct. Now, when we talk about the thoracic duct normally empties itself into the internal jugular vein. It empties into the internal jugular vein. then into the posteriorly to the clavicular insertion of the sternocleidomastoid muscles. So this is the anatomical position of what we are trying to talk about, or where the thoracic duct is. It is at the left internal inguinal vein, or that is where it empties into the left internal jugular vein. And by saying that, we are referring to what? The left venous corner. The left venous corner. Now, the right venous corner receives lymph from the right lymphatic tract. It receives lymph from the right lymphatic tract. But here we're talking about what? The thoracic duct, or the thoracic tract, the thoracic duct. So over here we are looking at what? At the jugular vein, and that's what we said, at the left venous corner. So your answer is what? Is B, left venous corner. I repeat, this is because the thoracic duct empties into the left internal jugular vein. The left internal jugular vein. As simple as that. Now, by the location, it is located on the posterior side, where there's clavicular insertion of the sternocleidomastoid muscle. So you just try to tilt your neck and see where your sternocleidomastoid muscle is, and try positioning this left venous corner way of insertion of the catheter. So again, answer is B. A patient has difficulties with hand movement. Okay. Examination revealed examination of the synovial sheath of the flexor muscle. You can't flex it, isn't it? It is known from the patient's anamnesis that he got a stab wound of a finger a week ago. Which finger are they talking about over here? Which finger are they talking about over here? Definitely, they are referring to what? The little finger. They are referring to the little finger. Because they said what? Examination is revealing what? It is known from analysis that he got a stab wound of a finger a week ago. Which finger was the most probably damaged, and for which there's what? An inflammation of the synovial sheath of the flexor muscles. So over here we're looking at what? At the fifth finger, or the little finger. Literally put, we are talking about the digitus minimus. The digitus minimus, meaning the smallest digit. The smallest digit. Now note. So you can take your finger, look into your finger again. Look into your finger again. Now, if you look into your finger, there's a gap between the bursa and the synovial sheath of the second, the third, and the fourth fingers. There is what we call the synovial sheath over there. Synovial sheath over there. And that is not common with the other places. And that's what over here, the most probable one will be what? Will be the little finger. Why? Because of the synovial sheath. The synovial sheath. The synovial sheath. The synovial sheath. Please, again, because of the synovial sheath, we are looking at the little finger, or the fifth finger, or the little toe, or the fifth toe. You know how you pronounce it. That is if you're talking about the toe, anyways, or the legs. But over here, we're looking at what? At the digitus minimus. The digitus minimus. The digitus minimus. The digitus minimus. All right. Anatomy is always very weird. Now, an injured man has a bleeding from the branches of the carotid artery. Carotid artery. For a temporary arrest of the bleeding, it is necessary to press the carotid artery to the tubercle of the cervical vertebra. So now you ask yourself, just try to bend your neck. Put your finger on your neck. You can feel a bone. You can feel a bone. You can feel a bone over there. You can just bend your neck, and then have a feel of that bone. Have a feel of that bone. Emmanuel, can you feel that bone?
Yes, sir. Yes, sir.
What bone is it? What bone do you think is it? If you bend, what cervical bone has that kind of protrusion?
C6.
Exactly. We are talking about the sit bone, the sit cervical bone. Thank you. The sit cervical bone, the sit cervical bone. So over here, we're looking at what? The sit cervical bone, the sit cervical bone, the sit cervical bone. So over here, that is what we have. That place, we also call it the carotid tubercle. Carotid tubercle, carotid tubercle. So please take note of that, the carotid tubercle. All right. And again, it is used as a landmark for anesthesia of the brachial plexus and the cervical plexus. It is used as a landmark for anesthesia of the brachial plexus and cervical plexus. It is a landmark. So after it, we have the T1, the T2, blah, 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 to T12. But over here, we're looking at what? At the V6. Sorry, that's a V6. C6. All right. Now, as a result of an accident, a patient has an intense painfulness and edema of the anterior crude surface. Dorsal flexion of the foot is hindered. The dorsal flexion of the foot is hindered. Guys, look at it. This is what dorsal. The dorsal, that means, how do I call it? Dorsal flexion. When you have your just try to pull or bring your toe towards yourself. Aha. That is called what? The dorsal what? Flexion. Try bringing it and go back. Bring it, go back, bring it. Good. That means you are flexing. That's the dorsal what? Flexion of the foot. And they said that place is hindered. That place is hindered. So what function of the cruise muscle is most likely to be disturbed? You remember I told you that the muscles of the how do you call it? The leg. We're having what? 3 groups of them. The longus, the brevis, and then the what? The how do you call it? The tibia, right? Those are the muscles. And we said both the longus and the brevis are located laterally. They are located what? Laterally. But the tibia is located what? Anteriorly. 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 And if you look at it, we want to, the dorsum, we want to bring our toe towards ourselves, but we can't. We can't. That's due that the anterior part is affected. The anterior part is affected. So over here, we are looking at what? At the tibialis what? Anterior. The tibialis what? Anterior. The tibialis what? Anterior. So your answer here is D. The tibialis what? Anterior. Great. All right. A 40-year-old patient complains of intensive heartbeat, sweating, nausea, visual impairment, and arm tremor, hypertension. Now, 2 years ago, he was diagnosed with pheochromocytoma. These are found inside the medulla of an adrenal gland. And inside the medulla, we talk about this, the GFR, that's the cortex. Now, the medulla is responsible for the production of what? Catecholamines. We talked about it. Catecholamines. That's the epinephrine, the norepinephrine, and so on and so forth. Please, if not watch all these pharmacology videos and physiology videos, please do well to watch them. The function of the medulla of the adrenal gland is responsible for the production of what? Catecholamines. All these flight and fight responses, they are produced from that place. So over here, if there's a tumor there and it's a vivid pheochromocytoma, then we are talking about what? Catecholamines. Catecholamines. So your answer was D. Catecholamines. All right. A patient who suffers from a cancer of the back of the tank, has an intense bleeding as a result of affection of the dorsal lengua artery. The dorsal lengua artery by the tumor. What vessels should be ligated to stop bleeding? Guys, we have what? The dorsal lengua what? Artery. This is just a branch. This is just a branch from the lingual artery. So if you want to stop bleeding, you go to the source, isn't it? You go to the source, because if you go and just cut the dorsal lingual artery, it could bleed again. So we have to ligate the main source, which is what? The lingual artery. The main source, which is the lingual artery. The lingual artery. So your answer here should be what? Should be lingual artery. Lingual artery. The lingual artery. All right. Good. A 58-year-old patient with acute cardiac insufficiency. Again, we've discussed a whole lot about cardiac insufficiency, the drugs to give and everything. And the 30% has what? A decreased volume of a daily urine. That means there's what? Oliguria. What is the mechanism of this phenomenon? What is the mechanism of this phenomenon? Again, there's a inadequate supply of blood, isn't it? So now if we have inadequate supply of blood, that's tell you that the volume inside the vessels will be decreased. The volume inside the vessels will be decreased. And if the volume inside the vessels are decreased, that means the volume that eventually enter into the renal artery will also be decreased. It will also what? Be decreased. That's what that's what. So if it is decreased, that means the amount of urine that can be formed will also what? Be decreased. Isn't it? So over here, we are having what? A decreased glomerular filtration rate. Decreased glomerular filtration rate. Why? Because there's a decreased flow of what? Blood to that area. So glomerular filtration rate will also what? Decrease. And as a result, there will be what? Oliguria, or reduced urine. Reduced urine output. So over here, we're looking at what? At a decreased glomerular filtration rate. Decreased glomerular filtration rate. Please find time and go through the videos. We've talked a lot about cardiac insufficiency, the drug to use, everything, chronic, everything. We'll talk about them. All right. Good. An 18-year-old was delivered to the hospital after a road traffic accident out here. Examination at the trauma department revealed a multiple injuries of soft tissues of the face in the region of the medial eye angle. The injuries caused massive hemorrhage. What arterial anastomosis might have been damaged in this region? Might have been damaged in this region. Again, we are having what? Multiple what? Injuries of the soft tissues. And as a result, it is happening at the place of what? The medial eye angle. So look at it. Your medial eye angle. Your medial eye angle. So that is what the problem is, or that is where the problem is coming from. Now, the injuries cause a massive hemorrhage. So again, you ask yourself, what artery is over there that can lead to that kind of massive hemorrhage? And over here, we're talking about the angular artery around the mid. So that's the median eye. From the name angular. So that's the angle, the area. So this is what we call the angular artery. The angular what? Artery. And this is the terminal segment of the facial artery. The terminal segment, or the last segment of the facial artery, which of course branches into the medial angle of the eye. So there's a hemorrhage, that means that place is affected. That place is affected. And what that artery does is that it undergo anastomosis, or it joins the ophthalmic artery. It joins the ophthalmic artery, the ophthalmic artery. However, the two big arteries that are connected to this are the external and the internal carotid artery. The external and then the internal carotid artery. Don't forget, the carotid artery supplies majority of the what? The head. The carotid artery, it supplies majority of the head. So every other thing will eventually be linked to it. Every other thing will eventually be linked to it. So over here, we are looking at what? The external, carotid external, and then carotid what? Internal. These are the major arteries that undergoes anastomosis with the angular artery. So your answer here is E. Is E. Again, if I were you, I would try and be looking at these arteries. After the presentation, try and look at them. And if possible, put them on a group page. Let your mate or your friends also get to know those arteries. All right. Now, after a 2-year-old child has had flu, there appear complaints about the earache. This one we did it the last time. So how is the flu connecting to the ear? So this person having what? Otitis media. So what's the connection between the nose and the ear? It tells you there's a tube. We discussed it called the Eustachian tube. The Eustachian tube. It's also known as the auditory tube. The auditory tube, or the musculotubar tube. We discussed all of these things in our previous presentation. So please do well to revise them. Now look, a doctor revealed that there's an hearing impairment, and inflammation of the middle ear. So guys, how did the infection penetrate into the ear? Guys, we are talking about the auditory tube, or the Eustachian tube. Eustachian, Eustachian tube. The Eustachian tube. All right. So the answer is B. A surgeon has to find the common hepatic duct during the operative intervention on account of concrement in the gallbladder. When we say concrement in the gallbladder, some people just refer to what? Gallstones, or substances inside the gallbladder. Sorry, guys. Refer to the gallstones. Okay. Now the common bile duct definitely is coming from the liver, and then the bile duct will come and join it. Then they will form the common bile duct. Then they will start draining into what? The ampulla. Don't forget the pancreas also come in. Okay, it also comes to join the all these bile ducts. They all come to join, and they all drain into the duodenum. They all drain into the duodenum. Now they are saying that during an operation of this, the common hepatic duct is located between what? So where can we locate the common bile? Yeah, the common bile duct, or the common hepatic duct. Yeah, the common hepatic duct. Where can we locate it? Where can we, or how? What are the demarcations? That's what it is telling us. So definitely over here, we are looking at what? The hepatoduodenal ligament. Hepatoduodenal ligament. Like I said earlier on, it is connecting from the liver to the duodenum. The liver to the duodenum. So if you look at that line too, you can locate this, this common bile duct. You can locate this common bile duct. Great. So over here, we're looking at what? Hepatoduodenal ligament. Hepatoduodenal ligament. I don't want to go into it plenty, but basically, that is, again, with a diagram, it could have been better explained. But this is anatomy. It could have been better explained. All right. A cerebral trauma, that is brain, cerebral trauma, cause an increase in ammonia formation. Guys, I talked to you guys about ammonia intoxication in pharmacology, or in one of the courses. We dealt with what? Ammonia intoxication. And we say usually it is the liver that is responsible for removal of what? Of this ammonia from the body. Okay. If not, the medication you can use is the lactulose. And again, the way in which the liver helps to remove the ammonia is that it converts into urea, which can then be excreted, isn't it? Good. Now again, to how does the brain also deal with it? So the question now is, what amino acid takes part in the removal of this amino acid? What amino acid is involved in the removal of this ammonia? What amino acid? Of course, we're looking at what? The glutamic acid. The glutamic what? Acid. The glutamic acid. The glutamic acid. The glutamic acid. Now, simply put, ammonia intoxication will occur when there's too much of what ammonia, too much of ammonia inside the blood or inside the brain. Why? Because of inability what to detoxify this what ammonia. Because of inability to detoxify this what ammonia, and it is detoxified by the use of what we call the glutamate or the glutamic acid. The glutamic what acid? The glutamic acid. So that is why over here there is what a problem. There's a problem. But then, if you want to know what amino acid is involved to remove these ammonia, of course, the glutamic acid. The glutamic acid. The glutamic acid. So your answer here is what? Is A. The glutamic acid. All right. A 40-year-old woman was admitted to the infectious disease department with a high body temperature. Meningal symptoms, guys. Meningal symptoms. That could be what? Inflammation in the brain, isn't it? Meningal symptoms. So it could be meningitis, it could be intracranial pressure, whatever it is. But how are you going to analyze it? We said it earlier on, you have to do what? A lumbar puncture. And what are you looking for in the lumbar puncture? You're going to assess the cerebrospinal fluid, isn't it? You want to assess the cerebrospinal fluid. And where is the location of this cerebrospinal fluid? That's the question. And it's located in the subarachnoidal space. In the subarachnoidal space, also called the spacium subarachnoidum, however you pronounce it. So your answer is what? Is B. The subarachnoid what? Space. The subarachnoidal what? Space. That is where the CSF can be located. And again, inside the bone, the lumbar, you locate it at what? Between the L3 and the L4. That's where you can put the puncture or you can insert the needle. All right. Now, after a recession of the middle third of the femoral artery, obturated by a thrombus, that's a thrombus, the lower extremity is supplied with blood due to a surgical bypass. Surgical bypass. Now, you know that the major blood supply of the muscle or the thigh is the what? The femoral artery. But here's the case, there's a recession of this middle artery, of this femoral artery. So now name the artery that plays the main role in re-establishment of the blood flow. Basically, we are talking about the deep arteries. Deep arteries. So you can do an anastomosis to connect it so it can supply the superficial. So that it can supply the superficial. So here we're talking about the deep femoral artery. The deep femoral. We have the superior and then we have what? The deep. But this one is what? The deep femoral artery. The deep femoral artery. So here your answer is what? Is E. All right. A patient's knee joint doesn't extend. Guys, look. Knee joint. A patient's knee joint doesn't extend. That means you cannot straighten your leg. So you can just try it. Try straightening your leg. That's what extension. Now, if you try to bend it, that is called what? Flexing. If you extend it, that's called extension. And this patient cannot extend the knee joint. There's no knee jerk reflex. Skin sensitivity of the anterior femoral artery is disturbed. Guys, skin sensitivity, that means a nerve, in the anterior surface is disturbed. So the question is, what nerve structure are damaged, or what nerve structure is found at the anterior femoral surface? What nerve is found at the anterior femoral surface? Of course, you are thinking of what? Exactly, the femoral nerve. The femoral nerve. So what nerve? What nerve? The femoral nerve. The femoral nerve. All right. I love this question because the easiest question. Electronic microphoto of the kidney fragment has exposed afferent glomerular arteriole, which has giant cells under its epithelium containing a secretory granules. Name these cells. Guys, you remember when we talk about the macula densa? You remember, yes. And we said what the macula densa does is that it senses what? Sodium concentration. It senses sodium concentration. So when it senses sodium concentration, it activates what we call the juxtaglomerular cells to produce what? Renin. Renin. So these are, or this over here, we are referring to what? Renin. Rennin. Renin or renin. However you want to pronounce it, just get the answer correct. So we are talking about the juxtaglomerular apparatus because they have a secretory with granules. They secrete renin. They secrete renin. They secrete renin. So over here, you are looking at the juxtaglomerular apparatus. This is not macula densa because in macula densa, you are basically dealing with what? Sodium concentration or a dense cell or a dense nuclei. But there's nothing like a dense. This is a giant cell. So giant cells are found in the juxtaglomerular apparatus. The juxtaglomerular apparatus. And they become active when the macula densa are in action, isn't it? Good. A 50-year-old patient was admitted to the hospital with complaints about pain behind his breastbone. Pain behind his breastbone. There's asphyxia during physical activity. That means inadequate, or definitely it's called hypoxia, okay? Or difficulty to breathe. So there's hypoxia during physical activity. Angiography revealed a pathological changes. Guys, look, in the posterior interventricular branch of the right coronary artery. Guys, we know that the coronary artery is what supplies the heart. I can't overemphasize this. It is what supplies the heart. Okay. But over here, it's a specific part of the heart. They said the posterior interventricular branch of the right coronary artery. What part of the heart are affected, or what heart part are affected? And over here, we are looking at what? At the posterior wall. The posterior wall of the ventricles are affected. So here, your answer should be what? The posterior wall of the right and left ventricles. Posterior wall. Even if you don't know, look at the name. That should one thing about anatomy is that some of the artery, the nerves, is based on the name of that organ or that tissue. Okay? So over here, we are dealing with the posterior wall of the right and left ventricles. So your answer here should be A. Your answer here should be A. All right.